Okay, thank you very much for the introduction. And I think Ghassan provided the view from an oncologist, and I think I tried to provide more the view from an hepatologist. And so one question I asked myself, so why do we need more drugs? And what do we need to consider specifically in HCC actually? And usually, of course, we want to have a clear-cut endpoint, positive or negative. We want to see improvement in overall survival. We want to see fewer side effects, quality of life. I think it's also getting more and more important. And I think our overall assumption is that when we have more drugs available, we can sequence them, and that will lead to a better and longer overall survival. And I think we have good data from colorectal cancer where we have exactly seen this. But in HCC, I think it's a little bit different. And here we really need to look more closely on liver function. And I have called it here the window of opportunity in HCC. And I think I can provide you some data that we only have a small window of opportunity for systemic therapy in HCC. So in the beginning, in early disease, when the liver function usually is best, we are trying to apply local therapies, resection with a curative approach, which is certainly the right way to go. In the more advanced disease, the window opens, and all the data we have are for CHIPUA patients. And the problem is that the patients will not remain CHIPUA. So many of these patients under systemic therapies will move to CHIPU-B and C, and with that, the window of opportunity will close. And with the REFLECT study, we have seen for the first time really this decline in liver function in a prospective study. And we really need to keep in mind that this are our best patients. I mean, they are fit, usually ECOG 0 to 1, CHIPUA liver function. And when you look here at this decline in liver function for the CHIPUA population, CHIPUA5 and A6, you can see that specifically in the A6 population, most patients rapidly deteriorate to a CHIPUA-B score, and with that, the meaningness of whether it's really a matter of the debate whether it's meaningful to still treat these patients with systemic therapy. And I think this decline in liver function is something we really need to understand better, whether this is just a matter of tumor progression and to which part actually our drugs also may contribute to this decline in liver function. And for this study, we can conclude that we do see a decline in liver function in both groups, but there's no difference between sorafenib and lenvatinib. And with that decline in liver function and this more and more patients moving to CHIPUA-B, you can see that we are not getting like 70, 80% of our patients to second line. Of course, I mean, at that time, there were not several second-line therapies approved, so we need to be careful and we need to see whether this will change in currently recruiting trials. But in this study, only around 40% of patients really were able to get second-line therapy. And having said in the beginning, having more drugs available, sequencing them will lead to a longer overall survival. And we have data here from the REFLECT study. When patients were able to receive second-line therapy, survival was significantly longer and much longer than the median overall survival we have seen in the past, and similar data has been presented for the ZORA-REGO sequence. So liver function is important, and we have seen the data for cabozantinib, and I think it's really important to remember that liver function might not only be prognostic, but it might also be predictive. Yeah? When we look at the median overall survival in the LB1 group or CHIPU-A5 group, we have a median overall survival of 11 and 6 months in the placebo arm, and only of 6 and 4 months in the group with a more advanced disease. So here clearly a prognostic impact. And when we looked at the predictive value, we have here in patients with a better liver function a hazard ratio of 0.6, and for patients with a more advanced liver disease, a hazard ratio of 0.8. And this is almost exactly what we have just seen for cabozantinib. Also this prognostic effect of liver function, and also the hazard ratio was better in patients with a better liver function, ILB grade A. So, I mean, the evidence adds up that liver function has both a prognostic and predictive role, which is important, specifically when we think about sequencing our therapy, switching from local therapies to systemic therapies. I think it really needs to be very clear that we will get the best results in patients with good liver function, and we really need to monitor liver function both during local therapies but also under systemic therapies. So Ghazan had a lot of positive data to report, and I can present two negative data. So the Nivo data, we have a press release. Again, I'm not sure whether today black is black and white is white. I think it's getting more grayish at the moment. So we have here a hazard ratio of 0.85. We, of course, need to see the data. I'm not sure whether we can really conclude that we have not seen an improvement in overall survival. We have not seen a significant improvement in this phase 3 studies, that is for sure. And the data from the Keynote-240 study has been presented by Richard. And again, the question is this really a negative study? I'm still struggling with the statistics, and for me, 0.023 was a positive study, but here it was a different predefined boundary of efficacy, so it's formally a negative study. If you put it into the context, and this was mentioned already by Richard, I mean, could we expect more or less? Usually we see in the phase 2 studies strong signals, very exciting survival data, which clearly and significantly drop in the phase 3 study. If you look at the data here from the 224 study and 240, I mean, it's exactly the same. And we have a median overall survival of around 14 months. This is the best overall survival we have ever seen in HCC, both in first line and in second line in a phase 3 study. So there is clearly a signal for these drugs in HCC. And when we put it then into the context, and Jordi asked, can we do a cross-trial comparison? Of course, cross-trial comparisons are always difficult, but having so many options available, I think we have to decide and we have to compare efficacy and toxicity. And when we look at overall response rate and survival, I think in green here, the phase 3 studies, the data for Pembro are looking very nice. We have good response rate. We have a promising median overall survival. So overall, maybe similar, if you like. When we look at toxicity, and this is of course also a major concern for our patients. I mean, TKIs usually do have toxicities, and when we look at treatment-related side effects with the antibodies, ramucirumab, and also with the immunotherapy, we usually see much better tolerability and fewer side effects, which are important, of course, also for our patients. And then, coming back to the first part of my study, I really think that in HCC, we really need to include the data on liver function. We need to understand the efficacy of our drug in patients with good and bad liver function. And we need to see how this decline of liver function occurs during systemic therapies. I have shown you the data in first line, but so far we don't really have these data, and they were also not presented for cabozantinib in second line, how liver function deteriorates, and the time to deterioration, and the number of patients that really move to Child-Pugh-B. And I can just share some preliminary data from the Keynote-240 study. So what is the impact of this immunotherapy? And we do know that we can induce a hepatitis. Of course, there could be a concern that the immunotherapy could have a negative impact on liver function. But when you compare these data, so what we have seen in first line is something we also see in second line. There's a decline in liver function, which is not related to the drug. In this case, there's no negative impact of pembrolizumab on liver function compared to placebo. And also with placebo, we do see a decline in liver function, which basically indicates decline of liver function is also significantly impacted by tumor progression. Again, making this window of opportunity small. And first of all, the prognostic and predictive value. If you look at these curves, and if you remember the curves we have seen for cabozantinib in the first talk, and also for ramucirumab, I have shown you there's clearly, again, a difference, a better efficacy in patients with an ILB1 compared to ILB2, and the median overall survival here for Pembro, 18 months in the ILB1 group, is very similar to what we have seen with cabozantinib in this setting. And again, we have this decline in liver function and the impact on subsequent therapies. Again, these are fit patients. They have a Child-Pugh-A liver cirrhosis, but only, again, around 40% of patients were able to get subsequent therapies. I mean, I think we can be happy that we have 40% of patients that are able to get third-line therapy, but of course, we need to improve these numbers even more to really get a meaningful improvement in overall survival. And so Ghazan has already mentioned these ongoing trials, and I don't want to show you all these phase 2 data. I think I have learned my lessons, and I will wait for the phase 3 data, and then I will get excited and decide whether it's good or bad. So I just want to go back and ask the question again, so what is the role of the immune system in the liver? And I think something we have learned from our preclinical models, and this was one study we published 3 years ago. Basically, the activation of the immune system, the hepatitis itself causes a lot of injury, or contributes a lot to the liver injury, and in the end also contributes to tumor development. So in our model, when we have immune-competent mice, they develop very fast liver tumors. If we take the same mice without an active immune system, these mice have a clearly reduced hepatitis and do not develop tumors. So here, there's a double-edged sword for the immune system in the liver. On the one hand, of course, we need the immune system, but it also contributes to injury and tumor development. And when we look at our data and the real-world data that have been presented, and which are in line with the data we have seen in the phase 3 and phase 2 studies, we do have these responders. We have patients with stable disease, but we also have patients with hyper-progressive disease. And I think this is something we also need to look very clearly which patient might really deteriorate under immunotherapy. So this is basically a mixed bag, and we really need to identify those patients that truly have a benefit from immunotherapies. And the next step will certainly be to look really in molecular defined subgroups. We have already seen data that based on the expression profiling, we have inflamed and non-inflamed tumors. And there are also some data indicating that activation of the Wnt beta-catenin signaling actually might lead to these resistance to immunotherapy. So in the study which has been published earlier this year, you can see these mutations in CTNNB1 or XN1. And in this group of patients, there were hardly any responders to immunotherapy. And if you look at the data on the outcome in patients treated with sorafenib, there was no predictive value for patients treated with the TKI. In contrast, when you look at these mutations in the Wnt signaling pathway, there was clearly a different outcome in patients treated with immunotherapy. So we already have some indications which factors might lead to resistance to immunotherapy, and we really need to look at this more closely and find these biomarkers to identify patients. So my take home here is multidisciplinary evaluation is clearly mandatory. It's critically important. We need to identify those patients that are candidates for local therapies. We have now drugs that lead to really amazing responses with systemic therapies, so we might even go back to local therapies once we have seen a strong response under systemic therapy. And here, these patients, of course, need to be identified. Personally, I think we do only have a small window of opportunity in HCC for systemic therapies because we have this critical impact of liver function, this deterioration of liver function under systemic therapies, which makes it really difficult to use or continue with systemic therapies. So overall, I think we really need to consider all. We need to see the data for survival, for side effects, quality of life, but also the effect on liver function. And only if we have everything together, we can really decide what would be the best choice in treatment. And as I said, at the moment, only 30 to 40% of patients really get second-line therapies, and this is our clinical trial population. And usually patients in real-world settings, they usually have a more advanced liver disease, and I guess we will not get these numbers in the real-life setting. So far, we have now convincing data for the best sequence. Ghassan has presented you all these positive data, but whether there's one special sequence, we don't know yet, and maybe we'll never find out. Probably we will have combinations in the future, which will make it even more difficult. And if I take everything together, so a significant benefit of the responders, moderate side effects, no effect on liver toxicity, I still consider immunotherapy as part of the HCC sequence. I think, of course, there will be reimbursement issues. I think today the world is not black and white. It's a little bit more difficult, and I'm very happy that we have so many ongoing phase 2 and 3 studies with immunotherapies, so we have plenty of opportunities to really identify maybe the best combinations, but maybe also the biomarkers we urgently need, and this would be my final word here, the biomarkers to identify patients for one specific therapy. Thank you very much.